Okay, so picture this. A 41-year-old guy comes into the clinic, and he's struggling with worsening shortness of breath. Not fun. Not fun, right? I mean, we've all been there with a little shortness of breath after, say, walking up a couple of flights of stairs. But this is something else entirely. This guy's symptoms are persistent and getting worse, which immediately makes me think, okay, something bigger is happening here. So naturally, the first thing we do is grab a chest x-ray. And what do we see? Well, there's a bilateral perihilar abnormality. That's just a fancy way of saying the central parts of the lungs near the heart are showing some mixed nodular and reticular opacification. Yeah, I know, radiology terms can get wild, right? But what's even more interesting is that there's blunting of the right costophrenic angle, which suggests he might have a small pleural effusion, some fluid building up around his lungs. Oh, and the heart size? A bit tricky to assess, but it looks normal, so we're not too worried there. Now, on the bones and upper zone vascular markings, everything seems fine. But you and I both know, X-rays don't always give us the full story. It's like they give you a sneak peek, but you really want that full Netflix series, right? So we move on to the heavy hitter, the high-resolution CT, or HRCT for short. Now, here's where it gets juicy. The axial images, those slices we love, show patchy ground glass opacification. And when I say patchy, I mean it looks like someone's taken a soft sponge and dabbed it all over the lungs. It's pretty clear something is going on in those alveoli. And wait, there's more. The interlobular and intralobular septa are thickened too. So I'm thinking, okay, we've got a mix of abnormalities in these lung segments. The lung apices are pretty chill, though, with normal lung parenchyma. Phew. At least something is behaving, right? Alright, so I'm sitting there thinking, what's at the top of my differential here? And what jumps out at me is pulmonary alveolar proteinosis. Ever heard of it? It's this super rare lung disease where the alveoli fill up with surfactant, which, while great for reducing surface tension, is terrible when it builds up like that. This condition gives you that telltale ground glass appearance and thickened septa we're seeing on HRCT. Plus, when you've got that crazy paving pattern, and yes, that's a real term, where the ground glass opacities mix with septal thickening, you've pretty much got PAP staring you in the face. But wait a minute, we can't jump to conclusions just yet. We need to keep a differential diagnosis handy, just in case. So I'm also considering things like pulmonary edema, acute respiratory distress syndrome, RDS, sarcoidosis, alveolar cell carcinoma, or even some atypical infections. It's always good to have a backup plan, right? Now, what's the next move, you ask? Well, time to call in the chest physician. We need bronchoscopy, maybe even lavage, to really get in there and see what's going on. This will help us clear out all that surfactant if it is indeed PAP. And who doesn't love a good lavage, am I right? But here's the fun part. Pulmonary alveolar proteinosis, or PAP, is not your run-of-the-mill lung disease. It's actually quite rare, affecting about 0.36 per 100,000 people. There are a few different flavors of this disease. Idiopathic, which is the most common, secondary, and congenital. The idiopathic form, which is the acquired one, makes up over 90% of cases, mostly affecting people in their 30s or 40s, not far off from our patient here. And if they've got a smoking history, boom, that increases their chances. Now, if someone's got secondary PAP, they could have been exposed to things like silica, titanium dioxide, or other chemicals, or they might have some underlying hematologic malignancy or an immune-suppressing disorder. In PAP, those alveoli just get packed with surfactant produced by type 2 pneumocytes, which, as you can imagine, makes it really tough to breathe. And speaking of symptoms, they tend to come on slowly, like sneaking up on you. The most common symptom is progressive shortness of breath, followed by things like dry cough, fatigue, maybe some weight loss, and occasionally chest pain. The craziest part? The radiological findings, the ones we're looking at, often appear way more dramatic than the patient's symptoms. So yeah, a bit of a mismatch there. The HRCT findings really tie everything together. Areas of ground glass opacity with that distinctive crazy paving pattern. It's like someone splattered tiles all over the lung field. There's no zonal predominance, and the pattern is scattered throughout the lungs. And get this, while crazy paving is classic for PAP, it's not exclusive to it. We can also see it in pulmonary edema, infections like pneumocystis pneumonia, sarcoidosis, or even alveolar cell carcinoma. So we've got to stay on our toes and get a bronchoalveolar lavage to clinch that diagnosis. Treatment for PAP-P, it's pretty interesting. We're talking about whole lung lavage to wash out all that extra surfactant. For idiopathic cases, this might need to be repeated a few times. And the prognosis? Not too shabby. Most patients can recover with proper treatment, though there are some reports of mortality ranging up to 30%. And in really severe cases, a lung transplant could be on the table. Crazy stuff, right? One last thing to keep in mind. PAP can be sneaky, especially in smokers. And sometimes it's associated with lung cancer, so we've got to keep an eye on that too. It's always something with this condition. All right, that's a wrap for this case. I hope you enjoyed this dive into pulmonary alveolar proteinosis with me. If you love this breakdown and want to keep the radiology knowledge flowing, make sure to subscribe to Radiology Made Easy. And hey, if you want to show some love and keep the coffee coming, check out the Buy Me a Coffee link in the description below. I appreciate all your support. It really keeps me going. Thanks for hanging out with me today, and I'll see you next time for another fascinating case. Take care.